As you said, the Trivandrum registry is one of the landmark registries which has given a lot of insights about Indian subset of patients with heart failure, and a lot of things are to be learned from that. Though we discuss in fora that we are not using the GDMT to the expected levels, but I think some inertia is always there, and I think overcoming that inertia is very important because the benefits of these drugs are overwhelming in decreasing the mortality, especially in heart failure patients. So how to choose the right ARNI? Because now we are flooded with so many drugs in the market, and many companies manufacture, some of them are locally also manufactured. Whether we have to go with them or how to choose the right ARNI in which kind of patient, that is what we are going to discuss briefly now. So as already mentioned, 9 out of 10 patients with the heart failure are symptomatic, even with current therapies. And each hospitalization for heart failure increases the risk of mortality further. If you look at the mean survival after the first hospitalization, it is 2.6. But as the time goes on with the second, third, and fourth, the mean survival decreases to 1.3. And in this, it is very important to also note that the time duration between the recurrent hospitalization becomes narrower and narrower. That is also very important. And therefore, the most important and paramount thing is to prevent the first hospitalization for heart failure. And there is a tremendous evidence which supports the first hospitalization can be delayed in these patients. We may not totally prevent it, but at least we can delay and give the patients a good quality of life for the time which they live. And the prevalence of heart failure is increasing. Actually, about 10 million patients are there now with heart failure in our country, and it's about 1% of the adult population. And post-admission mortality is very high. It is 20 to 30%. And also, we know that half of them are dead by the end of 5 years. And one important thing when compared to Western population is that our Indian population are relatively young people. And therefore, it's all the more important to focus on them because we don't want them to die young. And incidence of diabetes is also high. As we know, it is more than 50%, and hypertension is about 42% in our country. And medication adherence ranges from about 25% to 50%. And this is also one of the important points to be highlighted always. And there is a good data from our National Heart Failure Registry, again pioneered by a Trivandrum group of doctors. And it is conducted in about 53 centers in 21 states in our country, about 1,000 patients data. And most important and the significant etiological factor was ischemic cardiomyopathy, about 70%, I think. And about 25% were dilated cardiomyopathies, remaining contributed by rheumatic heart disease, etc. And in these patients, it was observed that the GDMT was only 47.5%. So guideline-directed medical therapy was given only in 47.5%. That is less than 50%. And the death rates were very high. Actually, the 90-day mortality was the published information from this registry, and it is 14.2%. And it tried to bridge the gap with the representation from diverse geographical areas across India, north, east, south, west, all together. So it reported one of the two eligible heart failure patients failed to receive the GDMT. And we can see here the various usage of drugs, the standard drugs, which at the time were beta blockers, AC inhibitors, RB, or MRAs, and ARNI. We can see ARNI was just coming at the time. This published data is 2022, not very old. ARNI was already there almost about 8 years. And very dismal usage of ARNI can be seen, maybe because of pricing, also one of the important factors that impacted the usage of ARNI in this data. And guideline-directed medical therapy is actually the foundation of heart failure care. And it is coming with the highest expected benefit, and it should be really prioritized. And we have to keep reminding our physicians and colleagues about this. And as already highlighted by Subhash Chandra, the latest guidelines also emphasize, and ARNI is recommended as a first-line therapy for heart failure with reduced ejection fraction patients by both ACC and also the latest ESC guidelines we have heard. In patients with chronic symptomatic HFrEF, treatment with ARNI instead of ACE provides a high economic value, and SGLT2 therapy provides intermediate economic value. But I think during the discussion, we can see whether usage of both these drugs can be having a additional benefit, because each hospitalization incurs a tremendous expense, especially in our country, because the patient pays out of pocket, and therefore it is always prudent to prevent the hospitalization for heart failure. And as I've already mentioned, as my earlier speakers and Dr. Tini Noyer also mentioned, usage of ARNI is very dismal in this Trivandrum registry. It is less than 4% in the Indian heart failure patients across the spectrum. At the time, I think HFpEF, there was no strong indication, but now we can discuss about the usage of ARNI in HFpEF. Dr. Subhash already mentioned some data that has come up in the recent ESC 2024 in the Lisbon. And if you look at the different spectrum of heart failure where we can place the sacubitril valsartan, it can be used in chronic HFrEF patients, and then patients who are hospitalized for HFrEF, and also people who are admitted with de novo heart failure or newly diagnosed heart failure patients, and also in patients with diabetes. And lastly, I think we can add a little bit about the heart failure with preserved ejection fraction, which also is seen like something like a tip of the iceberg. There are a lot of people who don't know that they have HFpEF unless we clinically do some echocardiographic examinations and various parameters. We look at it and also use NT-proBNP to make a diagnosis. Many of them think that their shortness of breath is contributed to by other factors like anemia or respiratory, overweight, all those things. But definitely underlying HFpEF is one of the important things, and the prognosis is equally bad for HFpEF as with the HFrEF. So firstly, the data about chronic HFrEF patients. I think paradigm HF, which was alluded to by Dr. Subhash Chandra, is the game changer in the management of heart failure with reduced ejection fraction. Till the time, we were mainly banking on AC inhibitors, especially we were using enalapril, then ramipril. All these things were used for heart failure. And this trial really was showing an additional benefit of 20% reduction when compared to enalapril in patients with heart failure and reduced ejection fraction. It is about 8,000 patients study, which has shown that primary composite endpoint of death and heart failure for hospitalization, 20% reduction was shown. And CV death, which is also one of the hard endpoints which we look at any therapy, 20% reduction. And then heart failure hospitalization, about 21% reduction was shown with sacubitril valsartan when used in the maximum dose of 200 milligram twice daily, as compared to enalapril 10 milligram twice daily. So this is really a game-changing trial for the ARNI, and it has become established as a therapy. And also the current guidelines recommend replacement of ACE inhibitor or ARB for ARNI in people with HFrEF. And also, what about the Indian sub-study of paradigm, whether our subset of patients compare the beneficial aspects to the Western? That was published by Jain et al. And in the trial paradigm, there were 637 Indian patients. So 322 were randomized to sacubitril valsartan and 315 to enalapril. And the composite endpoint was similar in Indian and global as well. And p-value for interaction was 0.5 in this heterogeneity study. And cardiovascular death, again, it was similar. And all-cause death was also almost similar when compared to global. And definitely our patients, though there are some demographic differences when compared to the Western population, like our body mass index is less, the incidence of diabetes is more, and our people are younger, even then the benefits were definitely on par with the global results. And next, we look at the people who are hospitalized for heart failure and reduced ejection fraction. This is a Pioneer HF trial, which has looked at the sacubitril valsartan initiation. And this was a good study because it initially looked at reduction in the NT-proBNP levels and also the clinical benefits of sacubitril valsartan in people who were treated from the acute admissions. They were taken up to 24 hours to 10 days. And then at 8 weeks post-discharge, the benefit was definitely there in these people also. Cumulative incidence of serious composite endpoints was lower and when in sacubital valsartan when compared to enalapril. There was a 42% reduction of CV death or rehospitalization with sacubital valsartan compared with enalapril in this study. At the same So we have stopped here at the de novo heart failure patients, and definitely there is a role for sacubital valsartan in people with acute heart failure as well. And initiation of sacubital valsartan keeps hospitalized patients alive and longer. And we can see there is a 20% reduction with the sacubital valsartan in this group of patients. And there is a 46% reduction also in these people with the heart failure and hospitalization. And in diabetic patients also, there is a definite benefit. And we can see that CV death and HF hospitalization is definitely favored in diabetic people. This is from the paradigm subset. There is again same 20% reduction in the risk of CV death and hospitalization in these people, regardless of their glycemic control. And it improves the LVEF in HFrEF patients and in diabetic as well. So the same thing here, the A1C reduction is also shown to some extent with this. And about the heart failure and preserved ejection fraction, I think this is one of the important topics. And it is shown in two trials. The one is the Paramount trial, which showed there is a decrease in the NT-proBNP, which is a biomarker for the heart failure. And Paragon is actually the clinical trial, which showed there is a decrease in the HF hospitalization, CV death, but it was found especially in women with the ejection fraction up to 50 and 57%. So beyond that, in this subgroup of patients, there was no benefit. There are, as we mentioned, there are several drugs that are flooded once the patent went off, and we have to use the drug that has good bioavailability and proven efficacy. And one of the important points here I put in the bullet is that JB Pharma, which is hosting the current discussion, it imports the drug from the Novartis company, which is the innovator. And there are certain points which we have to know about the molecule. This is a complex in crystalline form having different properties from the physical mixture of two active compounds. As you know, sacubital and valsartan, these are the two molecules that are put into a unique salt formulation. There is a 1:1 molar ratio of both these drugs, and there is a supramolecular complex with unique physicochemical properties and good solubility profile. Enhanced bioavailability of valsartan is there with this. And drug bioavailability is made more by the co-crystalline formulation. And there are some important attributes also which are tested in comparison to other drugs. There is a comparative evaluation of different brands of sacubital valsartan for the presence of co-crystallization. And one is X-ray diffraction studies, which have shown that the molecule that is available from the original Novartis and also Azmarda is the same. And also there are other things like optical emission spectrometry that look for the sodium content, and the sodium content is similar to the original, whereas in other products it is twice more than that. And surfactants are also studied, and it was found that none of the product had the same innovative lattice as that of the Azmarda, to name the product. And as I mentioned, there are sodium content that is more in the other products, and here the co-crystal complex is engineered with optimized sodium content to achieve better physical and chemical stability, hygroscopicity, and handling and storage. So dissolution also is important. It dissolves in acidic pH. The innovator product showed higher dissolution when compared to other products, especially now there are a lot of generics also available. I think we have to keep in mind the bioavailability of the drug is equally important, and these pharmacokinetic properties are very important when we choose the drug. So to sum up, I think sacubital valsartan developed by the innovator offers an unmatched legacy. There are more than, I think, 8 years of experience evaluated in 230 clinical trials, and more than 3 lakh patients are studied, more than 1,500 Indian patients as part of global clinical trials. And this is the original and imported molecule that is available for us. And I think price is also comparatively cheaper. And future lies with ARNI. That is my concluding slide. In ACS, hypertension, and also in other all indications in heart failure, etc. It is one of the important drugs that is available and useful now.